Therapeutic consideration: chelation therapy is the treatment of choice to get rid of acute and chronic deposits. In addition, cases of chronic exposure respond well to antioxidant therapy, especially ascorbic acid, calcium ascorbate, all-tocopherols, Vit. E, and an increased intake of sulfur-containing amino acids and Vit. B6. Arsenic suppresses iodine and selenium. Lead. Lead is number 2 on the ATSDR's top 20 list. Lead accounts for most of the cases of pediatric heavy metal poisoning, Roberts 1999. Sources of exposure: air pollution, ammunition, shot and bullets, bathtubs, cast iron, porcelain, steel, batteries, canned foods, ceramics, chemical fertilizers, cosmetics, dolomite, dust, foods grown around industrial areas, gasoline, hair dyes and rinses, leaded glass, newsprint and colored advertisements, paints, pesticides, pewter, pottery, rubber toys, soft coal, soil, solder, tap water, tobacco smoke, and vinyl mini blinds. Target tissues: bones, brain, heart, kidneys, liver, nervous system and pancreas. Signs and symptoms: abdominal pain, anemia, anorexia, anxiety, auto-exhaust, bone pain, brain damage, confusion, constipation, convulsions, dizziness, drowsiness, fatigue, headaches, hypertension, inability to concentrate, indigestion, irritability, loss of appetite, loss of muscle coordination, memory difficulties, miscarriage, muscle pain, pallor, tremors, vomiting and weakness. Lead is a known neurotoxin, damage brain cells, and excessive blood lead levels in children have been linked to learning disabilities, attention deficit disorder, ADD, hyperactivity syndromes, and reduced intelligence and school achievement scores. Lead is toxic to developing chickens, but chicks treated with an antioxidant, ethoxyquin, show significantly lower growth inhibition from PB, Donaldson 1991. This suggests that intrinsic antioxidant levels may influence susceptibility to some of the effects of PB. Additional factors affecting exposure and susceptibility to the neurodevelopmental effects of PB, Bellinger 1992, have been mentioned above. Therapeutic consideration: chelation therapy is the treatment of choice to get rid of high lead levels. Vitamin C, sulfur-bearing amino acids and other chelating agents can increase the urinary excretion and thus reduce toxicity and tissue overload, including that of bones. In acute cases of exposure, chelation treatments are recommended. Mercury. Number 3 on ATSDR's top 20 list is mercury. Mercury is generated naturally in the environment from the degassing of the Earth's crust, from volcanic emissions. It exists in 3 forms: elemental mercury and organic and inorganic mercury. Mining operations, chloralkali plants and paper industries are significant producers of mercury, Goyer 1996. Atmospheric mercury is dispersed across the globe by winds and returns to the Earth in rainfall, accumulating in aquatic food chains and fish in lakes, Clarkson 1990. Mercury compounds are added to paint as a fungicide until 1990. These compounds are now banned, however, old paint supplies and surfaces painted with these old supplies still exist. Mercury continues to be used in thermometers, thermostats and dental amalgam. Many researchers suspect dental amalgam as being a possible source of mercury toxicity, Omura et al. 1996, O'Brien 2001. Medicines, such as mercurochrome and merthiolate, are still available. Algaceeds and childhood vaccines are also potential sources. Inhalation is the most frequent cause of exposure to mercury. The organic form is readily absorbed in the gastrointestinal tract, 90 to 100%, lesser but still significant amounts of inorganic mercury are absorbed in the gastrointestinal tract, 7 to 15%. Target organs are the brain and kidneys, Roberts 1999, ATSDR Tox FAQs for mercury. Elemental mercury is easily converted to organic mercury by living systems. Symptoms of poisoning include inactivation of enzyme function, birth defects, brain damage and other central nervous system disorders. Early symptoms of mercury overexposure include insomnia, dizziness, fatigue, drowsiness, weakness, depression, tremors, loss of appetite, loss of memory, nervousness, headache, dermatitis, numbness, and tingling of lips and feet, emotional instability and kidney damage. Symptoms of acute toxicity: loss of teeth, extreme tremor, mental and emotional disorders, kidney failure. Sources: overexposure may stem from paints, explosives, electrical apparatus, batteries, mercurial diuretics, fungicides, fluorescent lamps, cosmetics, hair dyes, amalgams in dentistry, contaminated seafood, and petroleum products. Therapeutic recommendation: hair is a reliable measure of mercury body burdens, reflecting long-term exposure. Methylmercury, MEHG, is a potent neurotoxin exerting its greatest effect on the developing nervous system. Even among immature animals, the developmental stage influences the susceptibility of different brain regions to MEHG, Bartoloni 1987. Therapeutic consideration: chelation therapy is known to increase urinary excretion and is by far the treatment of choice. Oral detoxification procedures concentrate on sulfur-bearing amino acids, vitamin B6 and selenium. Cadmium. Cadmium is a byproduct of the mining and smelting of lead and zinc and is number 7 on ATSDR's top 20 list. It is used in nickel-cadmium batteries, PVC plastics and paint pigments. It can be found in soils because insecticides, fungicides, sludge and commercial fertilizers that use cadmium are used in agriculture. Cadmium may be found in reservoirs containing shellfish. Cigarettes also contain cadmium. Lesser-known sources of exposure are dental alloys, electroplating, motor oil, and exhaust. Inhalation accounts for 15 to 50% of absorption through the respiratory system. 2 to 7% of ingested cadmium is absorbed in the gastrointestinal system. Target organs are the liver, placenta, kidneys, lungs, brain and bones. Roberts 1999, ATSDR Tox FAQs for cadmium. CD is toxic to virtually every system of the body. It has been implicated in renal disease, prostatic carcinoma and other cancers, hypertension, anemia, Itai disease and anemias. It inhibits enzyme and nutrient utilization, and is readily stored in the kidney where it competes with zinc for binding sites in various enzymes and other proteins. Zinc, vitamin C, iron and/or calcium intake can partially protect against cadmium overload. Smoke increases the susceptibility to toxicity. Acute poisoning causes severe pulmonary and bronchial irritation. Source: pollution, smoking. Hair analysis reflects long-term, chronic exposure and tissue overload, and tissue levels increase with age. Cadmium has well-established nephrotoxic effects on the proximal renal tubule. Administration of ZN or SE with CD have enhanced the toxicity as evidenced by the release of tubular enzymes, Yoshida, 1993. Co-administration of GSH and N-acetylcysteine with CD did not inhibit its toxicity to cultured intestinal epithelial cells, Keogh, 1994. Therapeutic consideration: chelation therapy is the treatment of choice. Antioxidant therapy with emphasis on vitamin C also helps. Zinc and vitamin B6, increased amino acid intake. Water contamination and amalgam fillings are recognized sources of cadmium toxicity. Aluminium. Although aluminium is not a heavy metal, specific gravity of 2.55 to 2.80, it makes up about 8% of the surface of the Earth and is the third most abundant element. ATSDR Toxfacts for aluminium. It is readily available for human ingestion through the use of food additives, antacids, buffered aspirin, astringents, nasal sprays, and antiperspirants, from drinking water, from automobile exhaust and tobacco smoke, and from using aluminium foil, aluminium cookware, cans, ceramics and fireworks. ATSDR Tox FAQs for aluminium. Studies have begun to emerge about 20 years ago suggesting that aluminium might have a possible connection with developing Alzheimer's disease when researchers found what they have considered to be significant amounts of aluminium in the brain tissue of Alzheimer's patients. Although aluminium was also found in the brain tissue of people who did not have Alzheimer's disease, recommendations to avoid sources of aluminium has received widespread public attention. As a result, many organizations and individuals have reached a level of concern that prompted them to dispose of all their aluminium cookware and storage containers and to become wary of other possible sources of aluminium, such as soda cans, personal care products and even their drinking water, Annan 1993. However, the World Health Organization, WHO 1998, has concluded that, although there are studies that demonstrate a positive relationship between aluminium in drinking water and Alzheimer's disease, the WHO has reservations about a causal relationship because the studies do not account for total aluminium intake from all possible sources. Although there is no conclusive evidence for or against aluminium as a primary cause for Alzheimer's disease, most researchers agree that it is an important factor in the dementia component and most certainly deserves continuing research efforts. Therefore, at this time, reducing exposure to aluminium is a personal decision. Workers in the automobile manufacturing industry also have concerns about long-term exposure to aluminium, contained in metalworking fluids, in the workplace and the development of degenerative muscular conditions and cancer, Brown 1998, Barden et al. 2000. The ATSDR has compiled a ToxFAQs for aluminium to answer the most frequently asked health questions about aluminium. Target organs for aluminium are the central nervous system, kidney and digestive system. Copper, Cu. Copper is an important metalloenzyme. It is an activator of dopamine beta-hydroxylase, an essential element for proper adrenal function. The liver is the main organ for storage and excretion. Copper is tightly bound to the protein ceruloplasmin, to amino acids ESP histidine, threonine and glutamine and to albumin. These amino acids and albumin are important for the copper transport between the liver and various peripheral tissues. Toxicity symptoms include nausea, diarrhea, vomiting, discoloration of skin and hemolytic anemia. High copper levels are often accompanied by zinc deficiency, and long-term estrogen therapy can increase hair's copper levels, causing emotional instability and depression. High copper levels increase the toxic effect of selenium and suppress iron absorption. Excessive exposure and inhalation of industrial copper dust causes contact dermatism, cardiomyopathy, liver and kidney damage. Sources: whole grains, shellfish, nuts, organ meats, eggs, cocoa, chocolate, brewer's yeast and copper-rich drinking water. Copper IUDs have also caused elevated copper levels. Therapeutic consideration: chelation therapy. In Wilson's disease, copper levels are low in peripheral tissues such as hair. To normalize levels, evaluate iron, manganese, zinc and molybdenum levels. Vitamin C increases the copper mobilization and excretion, especially when used with amino acids and vitamin B6. Iron Fe. Iron is essential for the oxygen transport and utilization. Iron is regulated in the body primarily by absorption rather than by excretion. Gastrointestinal function is important in controlling total body iron. The most common sign of deficiency is anemia. Symptoms include fatigue, dizziness, energy loss and decreased immune function. Predisposing factors to iron deficiency may be excessive intake of copper, manganese, zinc, carbonates, oxalates, phosphates, phytates, antibiotics, coffee, or heavy metal exposure. Excessive blood loss or pregnancy can cause iron deficiency. Daily requirements vary depending on sex, age, and physiological status. The RDA is 10-18 mg/day. Sources: liver, other meats and green leafy vegetables. Therapeutic consideration: chelation therapy, check lead, copper and manganese levels. Prior to iron supplementation, increased intake of vitamin C, B-complex and amino acid to aid absorption. Some recently published findings related to the metal issue. Iron/manganese. A recent paper on Parkinson's disease, Neurology, June 10, 2003, 60:1761-1766, revealed that just by eating iron and manganese-containing foods such as spinach or taking supplements containing Mn or Fe, the risk of developing PD increased almost twofold. This demonstrates that even dietary supplements or organically grown foods are amongst the possible culprits in metal toxicity. Methylmercury. There are two major sources. 1. Mercury escaped from dental amalgam fillings is converted by oral and intestinal bacteria to methylmercury, which then is bound firmly to proteins and other molecules. Methylmercury crosses the blood-brain barrier and the placental barrier, leading to massive prenatal exposure. Earlier studies determined that over 90% of the common body burden of Hg is from dental fillings. Recent studies have revealed that eating fish is a leading risk factor for Hg poisoning. 2. Seafood. A recent study, JAMA, April 2, 2003, 289, 13-1667-1674, has revealed that nearly 60,000 children each year are born at risk for neurological problems due to methylmercury exposure in the womb. 1 in 12 U.S. women of childbearing age has potentially hazardous levels of mercury in their blood as a result of consuming fish, according to government scientists. The U.S.FDA recommends that pregnant women and those who may become pregnant avoid eating shark, swordfish, king mackerel, and tile fish known to contain elevated levels of methylmercury, an organic form of mercury. Nearly all fish contain some amount of methylmercury. Mercury accumulates in the system, so larger, longer-lived fish like shark or swordfish contain the highest amounts of mercury and pose the largest threat if eaten regularly. The National Center for Policy Research for Women and Families has suggested that the following fish also contain low methylmercury, published in May 2003, catfish, farmed. Blue crab, mid-Atlantic. Croaker. Fish sticks. Flounder, summer. Haddock. Trout, farmed. Shrimp. As per FDA, also fish like haddock, tilapia, wild Alaskan salmon and sole are safe to eat. Ethylmercury. As per Boyd-Haley, our latest research clearly points to the ethylmercury exposure as being causal in autism. The tremendous enhancement of thimerosal toxicity by testosterone and the reduction of toxicity by estrogen explains the fact that 4 boys to 1 girl getting the disease and the fact that the bulk of severe autistics are boys. This shows that exposure to levels of mercury that many